For my EBP assignment, I am doing the Achilles tendon rupture. To get the best information, I am looking at this from a post-surgical view. During this, I will be describing the goals of each phase and which modalities I would and would not use. For the first phase is the immobilization phase. My first goal is to properly teach the patient how to use crutches within the first 2 days out of surgery. My next will be to remove the patient from the boot in 4 weeks. To progress into the next phase, I will want my patient's pain to be decreased to a 2 out of 10 on a visual analog scale. During this, I will also be wanting to reduce the swelling to a minimum compared to the contralateral side and increase range of motion to reduce the amount of tendon adhesions. The modalities that I would use during this phase would be cryotherapy and massage therapy. I would be using a cryocompression cuff and an ice bag, and I can use them intermittently, and I can also use them while the patient is in a boot or out of the boot. The cryotherapy will decrease the secondary injury and decrease swelling the fastest. The cryocompression cuff will be used for 3 repetitions of 10 minutes, 2 to 3 times a week for 3 to 4 weeks. The ice bag will be used with an ACE bandage wrapping it from distal to proximal, tighter at the distal end, for 30 minutes, 2 to 3 times a week for 3 to 4 weeks. Massage will be used to decrease the swelling in the Achilles, and it doesn't cause high tissue heating. Effleurage will be the best technique to use during this phase to reduce the swelling and remove bacteria from the site. This will be used 1 to 2 times a week for 10 minutes for 3 weeks. The modalities I would not use during this phase are ultrasound, thermotherapy, laser, and electrical stimulation. Ultrasound would not be the most beneficial because of the tissue heating involved. It also doesn't benefit my goals of this phase. Thermotherapy could set my patient back up to 3 days due to the increase in water, oxygen, and enzymatic activity. And this can also cause the patient to have secondary injury, which is something I'm looking to prevent through this entire process. Laser would cause a more rapid healing and can re-rupture the Achilles. Laser shouldn't be performed until at least 2 months post-surgery, therefore it does not fit in the time frame of the immobilization phase. Electrical stimulation's main use is to regain the strength that is not a goal of this phase and would benefit the patient in the most effective way possible during this time. The next phase will be the progressive resistive exercise phase. The first goal I have during this phase is to teach the patient proper gait patterns within a week, being able to walk down and back in the room twice. My next goal will be to promote muscle re-education to achieve active contraction without instigation. For them to move forward, they will need to have an 80% of normal range of motion compared to the contralateral side. Dorsiflexion ranging from 0 to 20 degrees, and plantar flexion 0 to 50 degrees. I would also like the patient to reach 90% of the muscular strength by testing weighted dorsiflexion and plantar flexion compared to the contralateral side. I will also like the patient to be at 80% muscular endurance by jogging down and back twice without pain. During this phase, the patient should also be at 80% proprioception as compared to the contralateral side. During this phase, I will also like my patient to be at a 3 out of 5 on the AFQ, which is a confidence patient outcome questionnaire. The modalities I would use during this phase are cryotherapy, electrical stimulation, and laser. Cryotherapy will be used at the end of the day if there is pain and swelling from doing the strength and range of motion exercises. It will allow for an increase in nutrients and reduction of the secondary injury as the patient progresses. It will only be applied for 20 minutes after the heavy workload days. Russian electrical stimulation has the most success with the muscle re-education and allows for the pain to subside temporarily. This will be used for 10 to 15 minutes at a 10% duty cycle to have a post-contraction. The patient will be trying to match the contraction and hold it for an additional 5 seconds once the sensation subsides. Laser will allow for an increase in range of motion and strength. Laser increases the tensile strength of the Achilles tendon. This will also show the increase in range of motion and strength and give the patient a better confidence level. Laser will be used for 4 minutes at mode 3 for range of motion and 4 minutes at mode 1 for functional strength for 1 to 2 times a week for 2 to 3 weeks. Modalities that I would not use during this phase are thermotherapy, ultrasound, and massage. Thermotherapy can be beneficial and allows for tissue elongation and an increase in nutrients. However, ultrasound has the same effects as laser, but doesn't last as long as the deep tissue heating from laser. Ultrasound has the need for an increase in nutrients and increased collagen formation. Even though collagen realignment is important, it's not the most important part of the phase and would be seen more in the immobilization phase. For massage, the need for massage is not warranted because the swelling should be minimal to none and there aren't any physiological benefits from massage during this phase. Massage would only be used if the patient insisted on the treatment and then would only be performed once a week for 2 to 3 weeks. The next phase will be the functional stage. For this phase, my first goal will be for the patient to be at 95 to 100% of proprioception as compared to the contralateral side. I will also want to restore the patient's confidence to return to full safe activity with a 2 out of 5 on the AFQ. Patients' range of motion should also be at 95 to 100% of the normal range compared to the contralateral side. During this, I will also want the patient's muscular endurance to be 95 to 100% by running down and back twice doing a ladder drill with no pain. The patient's physical fitness needs to also be at 95 to 100% compared to a patient outcome score taken at the beginning of the rehabilitation process. During this phase, I will use laser, massage, and thermotherapy. Laser would be used to further increase the tensile strength of the tendon to its maximum potential, therefore also increasing range of motion and proprioception. Laser will be used for 4 minutes on mode 1 twice a week for 2 weeks. The purpose of massage is to break up any built-up scar tissue and adhesions on the Achilles tendon to allow for the last few degrees of range of motion and to increase proprioception to 100% compared to the contralateral foot. Myofascial release and effleurage will be used twice a week for 2 weeks as long as the adhesions are still present. Thermotherapy will also be used to get the last few degrees of range of motion and to allow for strengthening through tissue elongation. Thermotherapy will be used before games or a hard practice for 20 to 30 minutes. Thermotherapy will not be a constant use unless the patient is feeling sore or tight. Modalities I would not use are electrical stimulation, ultrasound, and cryotherapy. For electrical stimulation, muscle reeducation will be met by this point, therefore electrical stimulation is no longer needed. The patient will be performing active contractions and will be at a near maximal strength and range of motion. For ultrasound, the main reason I would use ultrasound would be to reduce any scar tissue, preventing full range of motion and proprioception. However, this can be better resolved through massage. For cryotherapy, there is no longer any need to reduce pain or swelling because it should be non-existent at this point of rehabilitation. There is also no physiological benefits of ice during this phase, but if the patient insists on ice, it will not hurt them to use it. The next phase will be our maintenance phase. The first goal of this phase will be for the patient's confidence to be at a 1 out of 5 on the AFQ. The next goal will be for the patient's range of motion to be at 100% compared to the contralateral side. The patient's proprioception should also be at 100% compared to the contralateral side. The patient's muscular strength needs to be at 100% by sprinting down and backs, lateral drills, and other sport-specific activity. The patient's physical fitness also needs to be at 100% compared to the patient outcome score from the beginning of the rehabilitation process. During this phase, I will use thermotherapy and massage. Physiologically, there isn't a need for heat, but it does allow for muscle relaxation and elongation. Relaxation and elongation are benefits that my patient will need even once they are full contact and can help prevent reoccurrence of injuries. This modality would be used as the patient needs at least 30 minutes before activity. Massage, myofascial release will be the massage technique that would be used to promote fluid movement and reduce any muscle spasms from being constantly active and in full contact. Massage would only be used 1 to 2 times a week for 5 to 10 minutes. Modalities that I would not use during this phase are electrical stimulation, laser, ultrasound, and cryotherapy. The goals of this phase don't permit any of these modalities. There are no longer any physiological benefits from these modalities because the patient is in full contact participation. These should also not be used because the patient is in full confidence in their ability to play and to not get hurt. These modalities are great benefits throughout the rehabilitation process, but at this point, the patient will no longer need